ankylotic patients. So we will discuss one case from beginning to end, and an intraoperative video will be shared with all of you. So my topic is temporomandibular joint ankylosis with interpositional gap arthroplasty, a step-by-step surgical workflow and technique. And I welcome you all and the distinguished faculty. Today I'm presenting a case that highlights one of the most challenging conditions in our specialty. I hope you all can hear me. Okay, good, thank you. So I'm presenting a case that highlights one of the most challenging conditions in our specialty, recurrent long-standing and long-ignored temporomandibular joint ankylosis. I will come back to the slide afterward. First, I'll let you go through the history of this patient. So our patient is 27-year-old young male who presented to our outpatient department with the primary chief complaint of a complete inability to open his mouth and severe progressive difficulty in chewing, accompanied by noticeable weight loss and nutritional compromise. His history is particular to be told and spans nearly 2 decades. This has to be understood that whenever we see such patients in our OPD, there is a long agonizing past with the patient has beard in his or her life, along with his family members, friends, and the relatives and the close associates. So in his 2 decades, at age 9, he suffered a blunt facial trauma after an accident involving a tractor in his home village. He began showing early clinical signs of progressive restriction in mouth opening at age 11, which was noticed by him as well as his mother. By age 14, his mouth opening had deteriorated to 0 millimeter. That means in time period of 5 years, his mouth opening was reduced from, you can say, 1 finger, 2 finger, or 3 finger to 0 millimeter. And by the age of 14, he was diagnosed for the complete extra-articular and intra-articular bony fusion. By age 16, he was taken to a regional facility where he underwent surgical intervention. And the operative notes, which we saw from the previous surgery, were mentioned that only gap arthroplasty was performed without an interpositional graft or myofascial flap. This point is very important. This whole presentation is dependent on this point. And by the age 16 to 20, the post-operative period, he enjoyed a 4-year period of functional jaw mobility. Once he reached age 20, he noticed progressive re-anchoring and restriction of his jaw again. And by the age 23 to 27, he had reverted to 0 mouth opening, living in complete jaw lock for 4 years before presenting to our clinic at age 27. It is worth to mention, which I haven't wrote here, that he is actually a very evident reader of the literature books, and he was unable to join school because of his facial deformity, because he was being bullied by his colleagues and by his friends in his school. So he left from the school, and then he continued his own education in his home. And right now, I had operated on him maybe 2 to 3 years ago. He is a lecturer in a college, in his school. So let's begin with the video. So here's a laser pointer. So on extraoral examination, you can see there are several pathognomonic stigmata of long-standing unilateral post-traumatic TMJ ankylosis. And you will also witness the surgical scar, a well-healed preauricular surgical scar from the initial index surgery. And on facial symmetry, you will find these symmetries in every patient. And in this patient, we found same. Whenever you are examining a TMJ ankylosis patient, you will notice a classic facial deformity. The affected ankylosed side displays a short, stubby mandibular ramus and body, while the non-affected side, that is the contralateral side, exhibits an elongated, flattened appearance with apparent fullness to compensatory deviation of the chin towards affected side. So you can see this is a limited mouth opening, or we can say the nil mouth opening, NMO. And the facial features I have told you There was a prominent antigonial notch on the ipsilateral side of the ankylosis. Why this antigonial notch appears is that not in the pathophysiology of the antigonial notch. But in a growing child, when a condylar ankylosis halts normal endochondral growth formation, you must be knowing about the intramembranous ossification or endochondral growth, condylar growth. So in the condyle, in the mandible condyle, there is an endochondral growth formation or the endochondral growth process. Because of the powerful masseter and medial pterygoid muscle pull continues to exert functional and downward tensile pull on the mandibular angle and the ramus. The muscle activity combined with the lack of vertical factor growth in the condyle causes dynamic apposition bone growth of the inferior border of the angle, resulting in severe attenuation of the antigonial notch. You will notice the antigonial notch. Let's play this video again. Apologies, I'm not that techy. So, see, this is a classical anti-gump appearance or uh, anti-gump appearance or retruded chin or bird faces. So this is a temporomandibular joint CT scan of that patient. Give me a second. So you can see a large ankylotic union of the condyle with the zygomatic arch and the glenoid fossa of the temporal bone. This is a large ankylotic mass, and you can see it is a recurrent mass. We don't have the previous CT scan record of that patient because that was not delivered to the patient at time of surgery. So you can see an elongated coronoid. His, his both coronoid were elongated because of the temporalis muscle pull. You can see usually when you see a CT scan of a normal patient, the coronoid ends here or maybe a bit here, but you can see only half of the coronoid and half of the coronoid is below the zygomatic arch. So whenever we plan a patient for the surgery, our treatment was gap arthroplasty with interposition and material and the bilateral coronoidectomy, and we achieved the mouth opening. So there is a master operative flow chart which we followed for this patient, which will be shared at the end of this presentation. But in the phase one, anesthesia is very important for this patient. Intubation in these patients is very, very critical, and it is a milestone for a team to achieve a good intubation in this patient. Due to 0 mm mouth opening, there is an option for tracheostomy or a blind or awake fiber optic nasal intubation. The center where I practice is very well equipped and we have very good anesthetists. So we did the awake fiber optic nasotracheal intubation for this patient. We didn't go for the tracheostomy. And this patient was placed in supine position with the head elevated slightly and turned towards the contralateral side. That means the head was turned towards the normal side because we have to operate on the affected side. The temporal preauricular areas and intraoral regions were prepped and wrapped to allow dual access to both the joint space and the temporal fossa. I'm marking the patient for the modified Al-Kayat Bramley incision in this patient. You can see we have kept this video on the fast forward because it was a long video. So the modified Al-Kayat Bramley preauricular incision with a superficial temporal extension gives us dissection carried out through the skin and subcutaneous tissue very easily. So I prefer endoral incision. You can notice there is an existing scar, very visible, a well-formed, well-healed scar. And previously the team uh, by whom he was operated, they must have followed their protocols. But when we saw the patient, I extended the incision toward the lower border of the mandible behind the behind the helix and auricle, and in the this is the auricle of the ear, and it is known as the end oral incision. It helps you to uh, hibernate the scar or camouflage the post-operative scar. So now we are raising the flap. You can see I'm using a 15 number blade. Hemostasis is very important in such patients. Facial nerve protection and the joint exposure is the key to achieve. To completely safeguard the temporal and zygomatic branches of the facial nerve in this patient, our dissection plan should be in subfacial plane at a point approximately 1.5 to 2 centimeters superior to the zygomatic arch. And an oblique incision should be made through that outer layer of the deep temporal fascia, which you'll be seeing in this video. So there is the judicious use of monopolar cautery, bipolar cautery, and the blade as well. So this is the fascia we have encountered, the superficial fascia, and now I'm incising the temporal incision for the temporal myofascial flap. So once you raise the flap, you see the flap is raised. Now you will see zygomatic bone being identified. This is the zygomatic bone. Now I will obliquely, I have incised with the monopolar cautery to go into the deep plane and identify the zygomatic fat pad. This is the zygomatic arch which has been exposed. Now I'm reflecting all the contractures and the soft tissue things away from my surgical site. A good team is very important to operate on such patients with you. And the delicate branches of the facial nerve were safely retracted out of the surgical field with the anterior soft tissue flap, exposing the dense periosteum overlying the ankylotic mass. Now you can see there is a visible ankylotic mass, and it was a huge ankylotic mass. Now we will proceed for the gap arthroplasty. So upon elevating the periosteum, the ankylotic mass was fully visualized, and a massive fused coalition of the condyle and the ramus and the glenoid fossa was identified. I'm using a piezo saw. For the superior cut, I prefer using piezo saw. For the inferior cuts, I prefer using mastoid, long burr, mastoid, round burrs. Those instruments are very handy because in the inferior cut, there is a chances of slippage and you can directly or inadvertently hit the internal maxillary artery, and that bleed is encountered is very, very difficult to stop. So we have done the superior cut. Now I have only marked with the piezo with the inferior cut, and I will use the long mastoid tungsten round burr, and we are doing the osteotomy with the help of chisel and mallets or osteotomes. So the superior osteotomy is performed just below the anatomic glenoid fossa to establish a pseudo fossa, which you will see here. And the inferior osteotomy is performed at the upper mandibular ramus, at the superior mandibular ramus. Minimum a wide gap of 15 to 20 millimeters, that is around 1 to 2 centimeters, should be resected. So there should be a pseudo fossa, and creating a wide space is non-negotiable in gap arthroplasty. The more wide you remove, the more mouth opening you will get, the less chances of recurrence. Why it is non-negotiable in gap arthroplasty is to eliminate the osteogenic binding or bonding again. Because the bone ledges are vascularized, they may regrow and patient will present with re-ankylosis as he was after his previous surgery. So after we remove this ankylotic mass, the bone ledges are smoothed using a diamond burr, but extensive, versatile, cold saline lavage is performed to clear every particle of bone dust which could otherwise serve as osteoconductive, nidus for recurrence. This is very important. Now you can see we have achieved some mouth opening, and now we are doing, I have done the bilateral coronidectomy of the patient, which are not included in this video. And after bilateral coronidectomies, I'm raising Temporalis facial flap. The periosteum or the pericranium will not be included in this flap. This flap is a finger-like flap, and it's a very robust flap. You can see we have kept the periosteum attached to the temporal bone. The 2 to 3 centimeter width of the flap is very much to maintain the vascular preservation. This flap is supplied via the axial blood supply from the anterior and posterior deep temporal arteries. And it is transported, once raised, it is transported over the zygomatic arch into the joint space, which you have seen in the video, without twisting or stretching the flap, because although it is a robust flap, but delicate hands are very important. So now I am setting it with the non-resolvable sutures into the pseudofossa. The pedicle temporal flap was rotated inferiorly over the zygomatic arch and transposed directly into the newly created joint space. The tissue was tucked in to fill the entire gap between the newly sculpted glenoid fossa and the ramus stump. The distal margins of the flap were anchored secure to the anterior remnants of the joint capsule, if there were, and the deep mesenteric fascia. In this, I did it with the deep mesenteric fascia. And this provides a robust vascularized autologous barrier that eliminates dead space and isolated raw bone surfaces. So when we did the condylectomy, the mouth opening of this patient was around 22 millimeters. Then we did the ipsilateral coronidectomy. We achieved around 32 millimeters. Then we did the contralateral coronidectomy, and his mouth opening was around 41 or 42 millimeters. So you have to achieve at least 35 to 45 millimeters of mouth opening of this patient to have a good post-operative life. You can see I'm stitching the temporal donor site to avoid the temporal hollowing. And this is actually, this video was recorded after the condylectomy, not after the coronidectomy. We have lost that video. So this is around 22 millimeters. And after the coronidectomy, we have achieved around 42 millimeters of the mouth opening. Okay, so next. So this is the master operative flowchart. You can take the screenshots. The awake fiber optic nasal intubation under local anesthesia and sedation was done, followed by the modified Alcayat primary preauricular incision plus deep temporal facial dissection. Then a subperiosteal zygomatic arch access and the facial nerve branch protection. The most common branches to be damaged or hindered in this surgery are temporal and zygomatic facial branches of the facial nerve. In the step 4, we did the radical ankylotic mass reduction. That was around 1 to 2 centimeters of bone gap created via the parallel osteotomies. Why these are called parallel osteotomies? Because one is the superior osteotomy, and second exact parallel is the inferior osteotomy. In the step 5, we did intraoral bilateral coronidectomies and achieved the inner mouth opening. In the step 6, we harvested the flap, which is inferiorly based flap on the posterior and deep temporal arteries. Worth to mention that pericranium was intact while raising the flap. We will discuss it in next slide. In the step 7, flap interposition and fixation was done, and layered closure and closed suction drains were placed. Awake extubation and aggressive post-operative physiotherapy was started after 24 to 48 hours after surgery. This is another slide which I would like to share with you guys. if you are starting such surgeries, and by the exam point of view as well. These are the superficial to deep facial planes that you will encounter till you reach the ankylotic bony mass. And number one is the skin, then is the subcutaneous tissue. Then you will witness the temporoparietal fascia, facial nerve runs in this fascia. Then you will witness or encounter the loose areolar tissue. Then you will see the deep temporal fascia, that is the outer layer of the temporalis muscle. Oblique cut is done in this layer above the 1.5 to 2 centimeter above the zygomatic arch to preserve the facial nerve branch. Then you will encounter the perizygomatic fat. Few surgeons find it, few can't. So this step is not important. Then you will come to the deep temporal fascia, that is the inner layer, and then the zygomatic periosteum. You will raise the periosteum, you will reflect it, as we have seen in the video. Then there will be a big chunk of dinner for you. Just take your instrument, spoon, spikes, knife, and cut the cake. Start cutting the cake. Okay, and next. Okay. So these are the important structures which we encounter in the TMJ gap arthroplasty surgery. That is the temporalis muscle. The origin of the temporalis muscle is temporal fossa or the temporal parietal fascia. It is inserted into the coronoid process and the anterior border of the ramus. Then the deep temporal artery is very important. They must be preserved. To preserve them, there should be a chunk of 2 to 3 centimeters base chunk of the flap inferiorly. You don't have to over thin the flap. Sometimes, because usually the temporal flap is very thin muscle, it does not hinder to be rotated and placed into the pseudo joint cavity. But if the flap is very thick inferiorly, you can carefully dissect it and carefully thin it, but not less than 2 to 3 centimeters. Because if you are planning to do this, then you might inadvertently or iatrogenically injure the feeding vessels for the flap, and the whole exercise will be failed. Then the facial nerve, zygomatic and temporal branches, they emerge from the parotid gland and cross zygomatic arch. They supply frontalis, orbicularis, oculi, and facial muscles. They run in temporoparietal fascia, as discussed previously, and they are protected subfacially. Then there's the maxillary artery. If it is bleeding or if you have encountered bleed, then what will you do? If you are brave enough, you can continue the surgery. And if you are not brave enough, it's better to just pack it and call the interventional radiologist or the vascular surgeon in our hospital. Both are available. We haven't encountered it yet, but I have heard from my seniors that if the bleeding from the internal maxillary artery happens, it is better to pack it for 15 to 20 minutes. It stops by itself. If it is not stopping, then involve the interventional radiologist or the vascular surgeon. They will stop the bleeding. If the bleeding still is not stopping, just pack the surgical site, close the patient, keep the patient intubated for 1 or 2 days, inform the family that we encountered intraoperative complication that is life-threatening, and we are planning to reopen it after 1 or 2 days. Or another option is you can terminate the treatment, just inform the patient that this injury is very life-threatening and we are unable to proceed. We may proceed after some time. So there are multiple scenarios which can be discussed in the discussion. We haven't encountered such complication yet. So it is not in our experience to how to manage such cases. Okay, next. So this is the myofascial flap architecture. Previously, we discussed the planes for the dissection. This is the flap architecture. It consists of the deep temporal fascia. Deep temporal fascia, the dense collagen, it provides suture retention. So every part of the flap is important. Muscle is used for the bulk, and it is supplied by the vessel. That's why it is needed. And the fascia is attached and taken with along with muscle, the deep temporal fascia along with the muscle, because it gives the strength to the flap and it provides suture retention as well. And then the temporal muscle belly, it is a vascularized bulky muscle. It helps obliterates joint gap. Then there is the temporal pericranium. Better not to touch it. Just leave it on the pericranium because it will. There are reported cases of in literature that it helps in heterotropic osteoinduction or osteogenesis at the site of the joint. These are the few potential complications which can happen during surgery or after surgery. Patient and palsy, maxillary artery hemorrhage, we have discussed recurrence of ankylosis and temporal fossa hollowing. So these are few questions which, when I was preparing for the exam, I opened my notebooks yesterday and took out some questions which were being asked from us, from our examiners. So why did simple gap arthroplasty fail in this patient at age 16? The answer is that simple gap arthroplasty without interposition leaves to raw exposed vascularized bone in close proximity in young patient with high osteogenic potential. Hematoma organization leads to fibrous union and osteoinduction is happening and eventual recurrence of the bony ankylosis. Question number 2 is why specifically harvest a myofascial flap rather than a purely muscular or post-facial graft, and why leave the underlying pericranium intact? Again, a very controversial question. 10 to 15 years ago, it was very controversial, but after the recent studies and the big case report series publication, it has been evident and agreed upon that you have to take the deep temporal fascia along with the muscle. Previously, in some centers, they were preferring only deep temporal fascia, some were preferring only muscle, but now it is important to take both of these. The answer of this question is number one, that is, it gives the structural and biological synergy to the pseudo joint. A myofascial flap combines two distinct biomechanical properties, the vascularized muscle body. Again, I am mentioning that the muscle is supplied by the vessel, not the deep temporal fascia. The vascularized muscle body provides rich blood supply and physical bulk to obliterate the dead space which we have created, while the deep temporal fascia provides less collagenous tensile strength required for firm suture retention when anchoring to the joint space. And prevention of heterotropic ossification, leaving the osteogenic periosteum or pericranium attached to the calvarial bone eliminates the transport of active osteoporotic cells into the joint gap. It is reported in the literature, directly preventing reossification and re-ankylosis. Question number 3 is why to perform intraoral coronaridectomies instead of extending the preauricular incision? It is because if we access the coronoid intraorally, it helps us avoid additional facial scarring and reducing the risk of facial artery or facial nerve injury, because we have to retract the preauricular incision and there might be excessive scarring and inadvertent injury to the facial nerve. And if we are doing intraorally, it allows direct, safe access to the insertion of the temporal tendon on the medial ramus. There is another question. When would you choose a total joint replacement over gap arthroplasty with the flap? So the TGR itself is a separate concept and separate topic to be discussed, maybe for 3 to 5 days or more. But I will give just a brief overview. That total joint replacement is preferred in adult patients with severe multi-recurrent ankylosis. Extensive bone loss where joint anatomy cannot be reestablished. However, in low resources settings like one which we are practicing, younger growing patients or cases are treated with autologous vascularized tissues available, and interposition gap arthroplasty remains an effective and reliable solution for such patients. How do you prevent the necrosis of the temporalis myofascial flap during the transposition? Seldomly it happens, but in a technique that is avoid over-tensing, stretching, or twisting the inferior pedicle of the zygomatic arch. Maintain a wide base that I have mentioned 3 to 5 times previously. 2.5 to 3 centimeters of soft tissue cuff inferiorly should be present to preserve the blood supply of the anterior and posterior deep temporal vessels. These are few surgical tips that you have to protect the medially to the ankylotic mass. You have to place a mandible retractor, a tongue depressor, or the orbital retractor, whatever is available in your makeup box, and always place a broad curved elevators subperiosteally along the medial surface of the condylar neck before making osteotomy cuts to shield the internal medullary artery from burst slippage. As I mentioned, my practice is to cut a superior cut completely with the piezo saw, and then inferiorly, I prefer just uh, delineate the inferior cut 2 to 3 millimeters with the piezo saw. Then I use the long mastoid burr. It gives me much control and manipulation. And the bone dust irrigation is very important because this bone dust has osteogenetic potential. It will it may help the surgical site to re-ankylosis. Bone dust created during the burning is highly osteogenic. It is also reported. Using continuous high volume of ice-cold irrigation. Why ice-cold irrigation? Because it helps in weather construction as well and keeps the surgical site clear. That is the Kaban rule. Tip number 3, you have to achieve minimum 35 millimeters. And tip number 4, again, leave the pericranium to stop re-ankylosis. Never elevate the pericranium or the temporal periosteum of the parietal bone during muscle harvest for temporomandibular joint gap arthroplasty with interposition. Dissect strict between the temporalis muscle belly and the pericranium. Introducing osteogenic periosteal cells into the resection gap is documented trigger for heterotopic bone formation. And and it is thank you from my favorite actor, that is Leonardo DiCaprio. I'm open for questions. Thank you. I hope I have tried to cover a 3 hour surgery in 20 to 25 minutes. Answer any questions. These slides will be provided all 3 lectures. Yes, we will try. These lectures are being recorded. I am recording them on my MacBook. I'm not that much techy that they are being recorded or not. I will check it after the end of the presentation. I'm open for the questions, or if not, I have answered all your questions. Then it's 11 o'clock. My daughter is also fine. So, you know, when to start post-operative visit after 48 hours. Simple. This current case, do we need to do preoperative angiogram to rule out gulfing of the maxillary artery within the callus mass? Medially, not must, but you can do if you have facility available. Not must. If you have facility available, you can do. But it depends on the surgical practice and surgical prowess and the surgical confidence of the surgeon and team as well. What if there is an artery? It will 100% or maybe in 90-95% cases, it will be in the proximity with the ankylotic mass. In fact, the ankylotic mass would be, touching it, or I'm unable to find a good word to explain, pushing the artery towards the medial side. So if if you have a well-paying patient, a good setup, you can go for MR angio, but we don't prefer really because we are working in very limited environment. Do you tell the patient about this possibility post-operative? Yes, consent signing. You cannot suture a patient without the consent. This is the TMJ surgery. We have video, written, and verbal consent signed. What is your intake regarding the atrophy of the temporal flap, and what should we do to uh, temporal flap seldomly atrophies in the joint space if you have a good cuff of 2 to 3 centimeters inferiorly. So it's seldomly, but if inadvertently it is lost or it is necrosed, then there are chances of recurrent ankylosis. How to manage temporal hollowing? Uh, invest this question is very being asked, but in the region which we are practicing, patients does not have any concern about their temporal hollowing. They just want to eat good. They just want to talk good. And this patient was very thin and lean, so temporal hollowing this patient would be none to negligible. But how to avoid it? Whenever I raise a flap, temporo uh, temporofascial flap, I undermine the remaining edges of the flap bilaterally. No, not the flap, the remaining donor site muscle. Undermine it and try to close it with little extension or tension. So the temporal hollowing minimizes. Is it possible to fix the resected coronae to restore the condyle? No, there is no need to do it. Would you place an abdominal fat? Yes, it can be placed, but it is an donor side morbidity. We have to retrap patient for another site, so it's better to do the temporal flap. How to reduce the relapse of ankylosis other than copious irrigation and leaving the periosteum? This question sounds very, chat GPT type. How to reduce the relapse of ankylosis other than copious irrigation and leaving the periosteum? I'm unable to get this question. Copious irrigation helps in, reducing the bone dust or removing the bone dust. That's it. In case of internal maxillary artery intravenous, why to wait 2 days till reopen? What is the rationale? Why not packing, waiting, intra? Yeah, it depends on the case. I gave you the scenarios. There are multiple scenarios. You can wait for 2 days. You can extubate patient with the pack. You can wait for 2 hours, then reopen the patient. So there are multiple scenarios. It depends on the surgical progress. If if internal maxillary artery is inadvertently damaged by me or my team member, I would rather not to pack the patient for 2 days or extubate it. I will wait for 1 hour or maybe 1 hour, 30 minutes. I will inform the patient's family. I will involve the interventional radiologist. Once the bleeding is concluded or stopped, I will continue my surgery. Very well explained, sir. Okay. In unilateral TMJ ankylosis, where compensatory maxillary cant is frequently present, do you routinely address a maxillary? No. This patient came to us with a history of previous surgery, very, very unaffording patient. I practice in a good, reputable private hospital, but this patient was operated free of cost. So it's better just to give him a good mouth opening to live a good life rather to give all the, orthognathic things. Later on, after 1.5 years, he still comes to me, and whenever he comes to me, he gives me a good book to read on Sinti or Urdu literature, and he's a very dear friend of mine. After that he has sent me hundreds of patients with oral cancer from his village. Like if you treat one good patient, and they will introduce your practice and your name into their vicinity. So we planned for his orthognathic surgery or the gastrectomy osteogenesis, but the patient also refused. He said that, sir, I'm very, very happy and this and that. I don't want to go another surgery. It's been 3.5 years or more than that. He is still living with 37 millimeters of mouth opening. Some surgeons advocate total joint replacement for recurrent ankylosis instead of, and what do you decide? I don't have any experience of TGR. Dr. Magan has done two or three cases in whole of the Pakistan, maybe not more than 3 or 4 cases have been done for TGR. It is very expensive, costs you around 3 to 4 million Pakistani rupees. So very technical. You need an extra fellowship, extra training to do the TGRs. Dr. Altan tomorrow will be presenting on the TGR, so it's better to leave the TGR discussion for tomorrow. Yeah, let me videographic. Especially, I hope everyone has seen the case. Would you please demonstrate in the video tissue layer pericardium that which should be preserved during? But I have to go back to the video. Then I will send the picture of that question in the group because मुझे वीडियो पे दोबारा चलानी पड़ेगी. We don't have much time. Are there any questions? ये यहाँ पे आ जाए. So, okay, this is the facial temporal flap. So here I have incised the periosteum just to know where is the periosteum. You have to visualize it. Okay. Now I'm just doing the muscle and deep temporal fascia. You will see the evident temporal, periosteum over here if it is raised. Now I have stopped blade or each and everything. I'm raising it with the back of the chisel periosteum. Now this is the intact periosteum. You can see there are the minute microvessels. If the periosteum is elevated, you'll see a plain dull bone. Okay, thank you.